Good morning, folks. My name is Jim Hanlon. I'm the CEO of COVE, the Center for Ocean Ventures and Entrepreneurship here in sunny Halifax, Nova Scotia. We're pleased that you could join us today for a special presentation by Dr. John Ross, who's the medical director of the PRAXES Medical Group. John is an emergency physician, and he's had a 30-year plus career in emergency medicine. He serves as the medical director and as the co-founder of the PRAXES Medical Group, which is a private sector telemedicine provider supporting remote sites around the world, including marine sites. He's also a provincial advisor on emergency care to the Deputy Minister of Health here in Nova Scotia. John completed his medical school at the University of Western Ontario, an internship at North York General Hospital, I have to say where my oldest son was born, and he did his residency in emergency medicine at Queen's University. He's a fellow of the Royal College of Physicians of Canada, specializing in emergency medicine. John's also a professor of emergency medicine at Dalhousie University, and he focuses there on acute airway management. He's also in past been a visiting professor in Dar es Salaam, Tanzania, where he did work in establishing emergency medical care in that country. John's married, has been so for more than 30 years. He has 2 sons. In his free time, he's involved in a number of sports, including sailing, which we just had a wonderful talk about as we were doing our prep for this. Enjoys traveling and spends time at his cottage in the mouth of the beautiful Leanness River here in Nova Scotia. I've had the pleasure of having a number of discussions with John and his team at PRAXES. Brilliant individual, wonderful raconteur, and a wicked sense of humor. So I know you're going to get a lot of good information out of today's session, which will be focused on marine operations and what the impact has been of COVID-19 and how those marine operations can manage a return to business in the presence of COVID-19. So without further ado, I'm going to turn the microphone and the camera over to John, and looking forward to an interesting discussion. If you do have questions, I'd invite you to pop into the chat session on Zoom, and I'll be trying to watch that chat session, and we'll be relaying questions to John at the end of his talk. Thanks very much, and over to you, John.
Thank you very much for that. That's detailed intro, Jim. That's great. I want to thank both yourself as well as Leslie and Kyle, who's doing some techno background stuff from COVE, for inviting me and making this opportunity available, because I think it's kind of we've been living this COVID business, certainly from our medical side of things, ever since it started to wash up against the Canadian shores, and I know that everyone's been trying to figure this whole thing out and where it fits for them. So I hope this is going to be useful. I will just just remind or reiterate the fact that I am an emergency physician. I'm not an infectious disease expert. I'm not a virologist. But I hope that I bring some pragmatic aspects to the COVID discussion, because we've been actually working with a lot of clients to try and help them figure out how they can continue to work in the COVID era that we now are finding ourselves in. So that's really the purpose of this exercise, is just to try and share some experiences, and then I really don't want to talk too much, so I want to open this up for questions from people. Both either general questions or whether there are specific things to your organization that you want to talk about. I'm guessing that it'll be useful for many that are attending. So again, thanks for this. So my goal is to just to kind of tell you a little bit about who and what is PRAXES. I'm not going to spend too much time on that. This is a marketing thing. Just a reminder about some of the basic healthcare needs of people who work in remote settings. And then we'll spend most of the time, of course, on just the COVID and marine operations impacts, some recommendations, and then open for questions. And the questions will be through the chat session thing, so because I know that you are currently muted. So again, really PRAXES cut its teeth on and has been in existence for 23 years now, providing medical support to those people who don't have access to the standard healthcare system. So when you push off from the wharf, your provincial healthcare system ends, and you're basically on your own to kind of figure things out. And companies provide that for seafarers, for employees. Individuals who push off on their boats are also kind of on the hook to try and figure out what to do if something happens out there. So we provide the 24/7 telemedicine service to those who contact us. We also provide medical kits to people. Again, there's a lot of confusion around what should I carry on a boat or in a marine setting or in my work setting. We've been doing this now again for a long time, so we have a fair amount of experience with what actually works and what doesn't. We do some staffing, and then we also do some occupational related marine type work. And we also work with a number of different types of clients. So here's a sort of an example, and I'm not going to go through them all, but we started off in the offshore oil and gas world, and then have luckily pivoted over time to non-fossil fuel industry. And so we just basically sort of cover off anyone who happens to be operating in a remote place is a potential group that may want to access some expert advice in remote medicine. So that's sort of what we do. So what's telemedicine? Again, really quickly, it wouldn't have been much of a knowledge item for many people prior to COVID happening. Nova Scotia was kind of slow to the game in terms of embracing telemedicine. Once COVID hit, all of a sudden the doctors Nova Scotia and Department of Health got together and started talking about, oh, gee, how do we provide virtual care for land-based patients when doctors aren't going to be able to open their offices as usual? We don't want to be getting too close to each other. So all of a sudden, telemedicine and virtual care became a thing. And so some of you probably have already had virtual care appointments with your family doctor. And so we keep it really basic for people that are working in remote places. The telephone is familiar to all. The satellite bandwidths tend to be pretty narrow still and kind of patchy at times. So that tends to work pretty reliably. So we start with people on the phone. We put them through some technology to hook up with our doctors. And so we have multiple doctors on call every day and across the country. And so that the system kind of figures out who should we be connecting with. Medical records are generated, and we can start communicating through, again, telephone, messaging, if that's appropriate. We send photos, and sometimes we do video if that's available. But a lot of it's just telephonic medicine. And that's sort of the essential of what we've been doing for the last 23 years. So there are, again, basic health needs before you leave. I think this is probably the most important, and is actually thinking about what could happen. And we've now been doing this, as I say, for quite a while. I can tell you that there's a long list of things that do happen. And so being prepared for that has real benefits. We find that some people are really good preparers, and other people don't think about this stuff until it's sometimes too late. So being prepared is a really key part of prior to going on trips. While you're at sea, there are basic sort of primary care issues, common colds and sort of funny belly pains and things, which are super common on land. They also happen at sea. We deal with those, but we also deal with the things that people often get the attention around, the heart attack and bad accidents and things like that. So it's kind of a soup to nuts job, and the telephone calls are always quite varied and interesting. And then the follow-up piece is that once people do get some kind of medical thing, how do we get them back to work and through family doctors, occupational health, or specialists, or whatever. So that's kind of the comprehensive care piece of not only people on land, but it's the same thing that happens for people who are working in a marine environment. So getting into the COVID piece of this story, this is a website that I look at several times a week at least, and I was looking at it pretty well multiple times per day when COVID first started hitting our shores. It gives you a Canada perspective, but you can also break it down into each province, and it gives you a daily update on the activity in each province as to what's going on. And the only thing I really wanted to point out here is that when you look at the total number of infections, and I'm just going to reduce this little panel on the side so I can see, there we go. This was I just took this one off yesterday, so it's not quite up to date, but it's pretty darn up to date. So 92,410 cases have been identified through testing in general, or highly suspected cases in Canada. And if you do the mathematics or the arithmetic that I just put in that little white box at the top, that number of diagnosed cases over the total population of Canada equals 0.2 of the population. So what that means is that 99% of the population still hasn't seen this virus yet. So when people are talking about, when will this COVID thing be over? When can we move on? The answer is it's only just begun, and we're almost all still vulnerable. So This is living with COVID. It's not living after, or when we start reopening, it's all going to be beautiful again. I mean, the reason that things have tailed off and leveled out to a kind of a constant number of disease cases per day across the country is that we're doing the physical distancing, and we're doing a number of changes in our various businesses and practices, and people are washing hands more, and people are wearing masks. All those things are contributing to the tailing off of the lack of an acceleration of this disease process. But it's out there, and it will continue to spread over time. So again, it's not over, and it's not going to be over for quite some time, unless we hear about the hallowed vaccine comes. But there are many people that say, listen, the vaccine's not a slam dunk by any stretch. The common cold doesn't have a vaccine. That's a coronavirus. HIV doesn't have a vaccine. That's been around for decades. So there are certain kinds of viruses that just aren't really amenable to a vaccine that's going to be effective. So keep that all in mind. Right. So this is really the get your head around it. And when we're dealing with especially younger folks, but really all age groups, there is this kind of kind of power battle between the human desire to want this to be over. Donald Trump saying, yeah, and then one day, like a miracle, this will be gone. Or Boris Johnson just said yesterday that he'd like to reduce the 2-meter distancing because it's kind of inconvenient for restaurants and other kinds of business. And so, I think we all get that concept of, boy, wouldn't it be nice if we could just make this go away? But the brutal reality is, and the reality check is, the virus has got biology and physics and chemistry that's making it work. And so it doesn't care about our human belief systems and our fantasies. And I put honesty on that underneath that little picture too, because the honesty factor is an important thing to think about when you're dealing with workers who want to go, if their job is dependent on how much fish they catch, or going out on a trip. You either get paid or you don't get paid. There are going to be people potentially who are going to minimize symptoms that could be COVID positive that they should be reporting, but they just don't necessarily want to bring it up. Or maybe there's a peer group pressure. They don't want to be like they don't want to be the idiot who could have COVID when everyone else in the group doesn't. So I think it's really important for employers to kind of think about what are the motivations of our people when we're starting to do rigorous checks on people. Are there reasons why they may be a little bit less honest than one would like, and will that affect things? So that's why I think that's an important thing to kind of keep in mind. Again, the reason that this thing is going to continue to spread and is spreading is that there's a proportion of people that don't have any symptoms. And again, if I was to look at the people who on that earlier picture of the country where I said that 0.2% of the population have been diagnosed, even if we said, okay, but there's a group out there that haven't been diagnosed, that had the disease, that actually got over it, probably have some degree of immunity. Even if we said that was 10 times that number, we're still only 2% of the population. So it is spreading both by people with minimal symptoms and are truly asymptomatic. And those are the problem children that we have in our group. And then we, again, in the shipping world and the marine world, we're going to be working in confined spaces. It's going to be really hard to maintain the 2-meter or more social distancing, physical distancing. There are no treatments. There's no vaccine. Oxygen can help those who do get sicker, but there's, again, only so much oxygen you can carry on a ship. And then serious illnesses do happen. And the good news around that is that from the onset of symptoms to the development of things getting worse, there are days involved. So it's not as if someone starts developing COVID symptoms and then within a few hours, they're now looking at admission to the ICU. It's going to be a multiple day progression. And the main reason for that is that once the symptoms begin, symptoms are often related to the immune system that's starting to kind of wake up and say, okay, there's something going on here. We need to kind of respond. And for those people who get extra sick, it's because their immune system has actually gone a little bit haywire and has really kind of overreacted. But that is a time delay thing that's not going to be immediate. So there is some time once you do see someone who is displaying some symptoms that could be consistent with COVID. Again, you can't carry a hospital on board your ship to completely set up with all the, full pharmacy. So there are going to be limitations and compromises that one has to make. And then we have to sort of figure out, okay, so what do you do about the person who now seems to be displaying those symptoms? Is there a place to keep them that can be isolated? How are we going to contact that person, keep an eye on them, give them food, get them to the bathroom, all those sort of basic requirements. You need to have pre-thought around what is our approach to that situation. And again, our goal is to not have the last bullet show up. We want to keep people who are potentially going to be sick, not available, and no virus on the ship. That's the goal. So here's an example of that not happening. So this is a large fishing ship. You can see it's got a crew of 126 people. They were doing an isolation apparently of like 5 days, up to 5 days, which is not 14 days. And then they were doing testing. And despite that, one or more of their crew got on board that were harboring the virus, whether they were asymptomatic or pre-symptomatic. And after a few days, all of a sudden, we're now into 85 of them. I mean, that's a disaster. And it's a disaster not only for the people that are involved in getting the illness, and I can tell you, we all know that not all seafarers are the picture of health. Some of them are going to be members of that risk group of older, some comorbidities, other health problems, and so on. So you have a disaster that's happening for the crew, but from a public relations company food processing business point of view, I mean, this is not cool. And so again, you can kind of imagine the fallout of this particular occurrence, and also taking that ship now out of action for some time to come while it gets cleaned and analyzed and so on. So a lot of paperwork got generated from that unfortunate slip in screening practice. So the other thing is that we've been sort of learning mostly early on in our time, and actually well into this, that this is a droplet spread thing, that 2 meters is a pretty good distance to keep. More evidence has now been coming out that's saying, well, yeah, that's mostly true. But if someone sort of at the height of their viral infection, that even talking like I am right now, actually, if I was infected, I would be exhaling virus into the air. And again, from this diagram, one can appreciate that for each exhalation, and these may be coughs or sneezes, so it's even more concentrated. But look at the distance of 2 meters is indicated. I don't know if you can see my cursor, but there's 2 meter mark, and here's a larger. That's the 6 meter mark. So it's lingering, and all you got to do is then walk along and take a couple of good deep breaths of this concentration of stuff, and you're now getting the beginning of a loading dose of virus that can have an effect. So it's not just droplets. It's not just dropping within a couple of meters. There is going to be an aerosolization of the virus in normal activity, especially heavy breathing, screaming, yelling, whatever, is gonna do more. So that's a problem, especially again in the asymptomatic person who's now is spreading the joy, which is why it's so important to be wearing a mask when out in public places where there are other people around, because twofold. One is you can protect yourself at least partially from walking into that cloud. But secondly, if you happen to be an asymptomatic viral shedder, then you're doing the rest of us a favor by trapping the majority of that material in your mask. And so wearing masks in public places, and we'll talk more about the use of masks in the first 14 days of being on a ship as a potential mitigation strategy also. So just basic kind of experiences. I think one of the things I've clearly learned over the last few months of talking to crews, many crews, is you really do need to explain with eye contact. And I've been encouraging companies to really get someone, whoever their leader is of the crew, to almost and maybe ideally sit down with each individual crew member, make eye contact and say, okay, so here's what isolation means prior to you coming on board our ship. It means that you need to lead an isolated life. We're lucky that many seafarers, certainly in the Maritimes, live in rural Nova Scotia, rural Newfoundland, wherever. And so their interactions with the outside world is a lot less than if you were working in an urban setting. So that's fortunate. But again, they still need to understand that if you have someone who's living in the household, who's coming and going from your house, who's working outside the home, working in a nursing home, or working in a hospital, or working in a business of some sort, they're going out and they're potentially bringing back virus during your isolation period. Going to the stores and so on. So all those things need to be understood. And this is really kind of like an extra mindfulness time where we need to be looking at where are my hands when I'm out and around? What does the social gathering thing mean? What are the risks, and what is the prevalence of the disease in my area? So again, currently we're in a dip phase. The prevalence of virus out there, especially in rural settings, is really low. Not zero probably, but really low. And so again, the likelihood of picking it up somewhere right now is certainly less than it was a month ago. But there's still are risks. So the importance of self-isolation. Again, we've been strongly advocating that if at all possible, in fact, it's really mandatory. People should be, before getting on board a ship, if you don't want to bring virus on board, you should be isolating either self, or people are staying in hotels and doing a more strict version of that. You should be doing that for 14 days. That's the time period where the symptoms, if you have an infection, are going to show up. Or if you're asymptomatic, your body will have worked through the immune system and will be able to kind of beat this thing down by the time the 14 days have passed. And so again, you should be as close as we can get to a green light to be able to get on and say, okay, yeah, you know what, you've passed that time period. You are viral free. We now need to get you to your departure point. And so that's the third bullet at the top part, saying the safe travel to the work site. And so here's an example of this is a real life example. So 14 days of isolation by individual crew members for a certain group. Seemed to do a good job, I think. They were truly isolating, appropriately, living with their family and not getting a lot of outside, activity. Great. So then they got a 4-hour trip between where these guys live to where they're going to be joining the ship. And so they decide, well, why drive 4 different vehicles? Let's just drive one. So they all pile in together, and they drive the 4 hours to the departure port. And then during our screening, we actually are providing some screening for various companies with a health professional. So we're going through, and then one of the 4 guys ends up having a fever on screening. So we didn't appreciate his fever, but he had a fever. So that then means that the other 3 guys that drove with this person are now out of the game too. So they all have to go and isolate in a hotel or motel and wait for the results of the guy with a fever. Well-intentioned, not malicious, played by the rules, but just let that slip and just didn't kind of, keep in mind that you do need to kind of isolate yourselves individually until you can be screened as a final sort of step before getting on board the ship. So again, a sad slip that cost everybody time and grief and lots of eye rolling. So again, you've got local crew, understanding that. You may have people from other provinces. Again, there are provincial rules around that right now, around how, again, the downtime or going directly on board and isolating, or however it's going to be done. But I think, again, the goal is to keep the virus off the ship. And I appreciate that there are costs involved of having people sit around for 14 days doing nothing and having to pay for a hotel room. And I totally get that. But the cost of that inconvenience, the inconvenience to people don't want to do it or whatever, it doesn't matter. The virus doesn't care about the inconvenience and the cost and the desire to not have to do this. The virus says, yeah, good. You want to put people together who one guy has a virus, one guy doesn't? I'm happy with that. I can make this work for me. I'm going to jump across. So you got to keep that in mind. Specialists that are coming from other countries and so on, those who who are part of the essential services and don't have to isolate. I think you just have to be super wary. If that person, for whatever reason, doesn't have to isolate, and you're going to put them on board your ship, and you don't really know what their true status is, there better be a plan for cleaning and monitoring and gowning this person, because I don't totally get the essential services. You don't have to isolate rule. I just can't quite get my head around that one. So certainly testing has been a really popular thing. Well, great, there's a test out there. Can't we just test our people? We can get rid of this, or at least we can reduce or maybe even eliminate the isolation piece, and the test will tell us the answer. Are they good to go or not? Obviously I'm going to spend a few minutes on this, because that is absolutely just not the case. It's not how it works. So I know this looks kind of complicated, but it's not complicated really at all. And so medicine is not, and medicine tests are not like the metrics or the instruments that one uses, again, in the marine industry or other places, where it gives you a number that is kind of an accurate number, as long as the test is being done properly, the machine is calibrated and so on. Medicine is a series of probabilities, and so you gather a history, you take a good, solid story from someone, you do a physical examination, you maybe decide to do a test or two, and maybe an X-ray or two, whatever, and you come up with a series of yeses and nos that you then put together to affect your assessment of whether you think this person has this problem or not. So it's not black and white. It's not like a pregnancy test, which is close to black and white. Yes, no, you're pregnant. Even that is not sort of perfect either. But in the case of the COVID test, is a viral RNA test. So it's looking for a specific infection that you have right this moment. But it doesn't perform like a yes/no test. It performs better if the test is positive, and it's not that great when the test is negative. So so I kind of said that what I want to do is I want to basically get a history from this person. So, have you been exposed to somebody with COVID, possibly? Are you living in an area where there's some prevalence of the virus? Are your symptoms potentially consistent with what could be COVID? So, I take the history, maybe do an examination, listen to the chest, and get the oxygen saturation and so on, and say, yeah, well, you got some features of COVID, but then it's not super convincing. It's kind of a 50-50, 50% chance that you could have it. And that's my pre-test probability, which is along the bottom axis, the x-axis. So then we do the test and do the swab, and it comes back, and it's a positive test. So for a positive test, what you do, looking at this graph, is you go to the upper curved kind of convex curve, and you draw a line up from the 50% pre-test probability, and you end up with a post-test probability of around 90%. So a positive test in the setting of a 50-50 sort of case will improve your post-test probability, saying, yeah, you know what, you've got a 90% chance of having COVID. So that's a useful test to kind of, basically make the diagnosis. Okay, yeah, you're COVID positive. We need to kind of, do whatever as a result. Let's say I'm 50-50 on this person. I do the test and it's negative. Well, a negative test is going to give you a different kind of outcome. So if we draw to do a straight line up from 50, the lower convex curve is the one you're going to use for negative tests. And so what I've done is I've reduced my pre-test probability of an iffy 50-50. There's still a 25% chance that this person could be positive, that this was actually a false negative test. And so the problem with this test is it's a good rule-in test. I said, I think you probably have COVID, and you have a positive test, and therefore, you know what, you've got COVID. Versus, I think you might have COVID, and then I get a negative test. I can't say for sure that you don't have it. I can say, well, it's a little bit less likely, but I'm still not, I don't know. So it's a good rule-in test, but it's not a good rule-out test. And what you guys are looking for is you're looking for a test that will rule out virus in each one of your crew members prior to them getting on board a boat. And so this test, used in the incorrect setting, is not going to achieve that goal. We do use the test for some clients of ours, but the people that we're using it with are people who are doing a strict isolation for 14 days. So they're reducing the pretest probability to a really, really small percentage, a small number. And then we're doing the icing on the cake test. And we're doing it twice in many cases, because we know that there's still fallibility of this test. So we're doing it twice as the icing on the cake to say, okay, listen, we've done a really good strict isolation. That really honestly is good enough if you do it well. But let's do a test on top of that in that setting. And now I can reduce the probability to a really small acceptable number. But to use it on the general public and say, are you positive or negative? That's going to be my decision tree, is an incorrect and improper use of the test. And so it can't be used willy-nilly in screening our seafarers. I hope that's clear, and I'm happy to answer questions later on about that. The other testing out there is the antibody test, which really is a retrospective test. It's asking, do you have antibodies to a previous infection? And so that would have been days, weeks ago. It's not going to be useful for you sort of prospectively asking, can this seafarer get on board a ship prior to departure? Are they COVID free? That would not be the test you want to use. So we've been asked by a number of companies, can they start using the antigen test as their kind of standard? And the answer is absolutely not. Would not be appropriate. So you have to be vigilant once they get on board the ship. So extra PPE, cleaning vigorously. You should have a medical kit that's reasonably comprehensive. The first 14 days, we suggest that you should be doing daily temperature checks. I kind of am in favor of twice a day, ideally, because it just gives you an earlier pickup if something is starting to brew, and it reduces the touch piece of that person wandering around for a further 12 hours. You should be asking, guys, you got any new cough, any new sneezes, belly sore, whatever. And I mentioned the cleaning already. And then again, what happens if people do have symptoms? And there's a bit of a difference between the young healthy guy versus the older and unhealthy. You might decide that you, depending on the project, whether you might want to try and see if they can just resolve on their own. We know most almost 85% of people are going to do fine from their COVID, just feel crappy for a little while. The older, unhealthier person, I would be getting them off the ship as soon as possible. Again, we have days to kind of work with, but the sooner the better. You do have to contact shore, and you have to have an isolation room. So you need to think about, what is our approach if the worst of the worst does happen and someone develops symptoms. You're going to communicate to everybody, explain this, you're going to re-explain it, you're going to re-explain it one more time, because people, the change management process is painful. And then there are a number of kind of basically regulatory things that you need to be aware of. This is actually just a nice infographic that's provided by the Public Health Agency of Canada in collaboration with Transport Canada. And I think it's again, sort of a quick summary of what the things that you need to consider and know about. And there are lots of regulations around health reporting when returning back into a port, in terms of timing and letting people know what's happening on board your ship. So those are all regulatory requirements, and I won't spend any time on that. Again, resources available. Again, if anybody wants copies of this particular presentation, we'd be happy to send those out. This is some of the references that I've either referred to, and just some other ones that I didn't necessarily talk about, but certainly very good, easy reads that do explain a number of things. The Fisheries Safety Association, I should give them a plug. I think they've done a good job for smaller vessels in terms of some really good information that they've posted on their websites. And there's also a good video on just the use of PPE. So it's not just like you're putting on work clothes and take them off again. There's certain ways, especially when you have someone on board your ship who you suspect could be COVID positive, you can contaminate yourself very, very quickly, and which is why healthcare workers, if they have the PPE at all, why healthcare workers are certainly at risk of getting COVID, because there's really specific ways to take this stuff off without getting virus on you on the way off. So it's a good video to watch on how to do that. So I'm open to questions, and I'll maybe turn over to Jim, and I'll just put that up there for your information. If you want to contact me or Michelle, who's our operations manager, who I think is also on the presentation right now, be happy to try and answer questions along later on too. All right.
John, that's fantastic. Wonderful set of information and certainly very helpful. I have a few questions, but there's been some coming in on the chat line as well. A couple of the questions revolve around, are these slides available? And I think you just answered that. So yep. Certainly they are either directly from PRAXES, or if it's easier, we can pass them on your behalf. So yes, by all means.
And I think if I may too, yeah. Just if the recording can go along with it, then obviously that would be kind of helpful, because they are kind of a little bit dry statically.
Yeah, so normally at the end of these, we send out a follow-up survey to those that have been online, and included with that would be a recording of this and access to the slides. So if you're looking for more information, for those of you who have been taking copious notes, I apologize. You do get the slides and the recording after the fact. A question's come up that I'm fascinated by, and it really revolves around, what about the short trip situation where a researcher is going out for a day trip in Bedford Basin or offshore, or a fisherman is going, or fisher is going offshore for a day trip? Practically and pragmatically, what steps can they take short of isolating for 14 days to go for a one-day trip?
Yeah, no, that's a good point. I look at many of those kinds of situations as being basically the same as what you do on land. I think ideally you would like to have the people that know ahead of time they're going to be doing that they are minimizing their contact. Again, the 14-day period is a pretty magic number. It's based on knowing that it's probably closer to 11 days, maybe 12. 90, I think 97, 96% of the population will have done something by that time period. But the 14 days is kind of rounded out, which is probably not an unreasonable thing to do. But for those who are going out for short trips, I think getting virus on the ship, if it ended up happening, is far less of a disaster than for a number of our clients that go out for 5-6 weeks at a time, even several weeks at a time. They're going off remotely. It's a costly, technically, logistically difficult thing to have to turn that ship around or organize a medevac. There's weather involved. And so those ones are the ones that we're really kind of focused on, saying we need to kind of be absolutely rabid in our attempts to keep the virus off the ship. If you're going out for shorter time periods, you're going to be able to come back and return if somebody starts displaying symptoms. It's going to be annoying for sure, but then you can go through and you can clean known contact surfaces, and you'll have to do the contact screening and so on. But I would say, yeah, shorter trips are less of an issue. I would still encourage people to try and those who are in this kind of work environment, partying in a crowded dance hall, getting wasted and not remembering what you were doing is not a good practice, and it's going to be COVID friendly, which is not what we want. So I think people just need to be kind of, again, mindful and wary about that.
Just react. Would PPE help in those kind of confined spaces? For a day
trip
on ship.
Yeah, it's good. So that's a good point. I didn't really sort of say that enough, but I PPE. I mean, I don't think you have to wear the full hazmat suit. I think for sure wearing a mask, this surgical or just even the cloth masks that people have been making is a good practice, and it goes back to that graphic with the sneeze, cough, talk cloud. You're going to be helping out those with you if you happen to be one of those asymptomatic viral shedders, and you're also going to be protected from somebody else. So I think, again, especially for day trips or several days out at a time, I think when you're out of your sleeping zone. I just stick the mask on when you're going to be interacting with other people. And we've been saying the same thing for the first 14 days of groups that are going out for longer trips. So the 5 weeks of or 6 weeks of shrimp fishing south of Greenland group. Temperature checks regularly, cleaning everything, social distancing. You don't get to play cribbage and cards for the first little while. Wear a mask when you guys are hanging out together, if you can possibly get your heads around that. It seems goofy, but once the 14-day period for that longer group is done, then you basically have proven that you're okay. You can relax that stuff. But I think, yeah, short trips, hand washing, mask wearing, distancing when possible, are all good strategies.
Another question's come in, which is kind of related. So what about situations where seafarers may be working for more than one employer and moving between vessels, either on land or, God forbid, a situation where you're transferring an emergency patient between ship A and ship B for obvious reasons? Any recommendations, any thoughts on those situations?
Well, so I mean, ideally, if you're on the ship in the first place and you've followed the rules, you should be going from a non-virus ship to non-virus ship, theoretically, right? Yeah, I think the Coast Guard, also one of our clients, is kind of faced this. What if we go out there, we've done our thing, but our job is to go and respond to people's emergency? We have a ship that now has a viral guy on board that we've now got to transfer for whatever reasons. What's that all going to be about? And they've got they now would be putting on full PPE to handle that sick person. But yeah, people who are working on multiple things, it gets a little bit like the people who've been working in multiple nursing homes.
Yeah, I was just going to say.
Right. I mean, it's now again, that was a higher risk group, a more vulnerable group. You're going ideally from a sterile ship to a sterile ship, but boy, I think what I keep encountering and I'm going to keep emphasizing is that picture of the fantasy thing. I think people want it to be a certain way, but the virus doesn't care about what makes fiscal sense for us. What's the cheapest? What's the fastest? What's the whatever? The specialist technician guy is only in the city for a little while. He's got to go to 3 different ships. We better know who this guy is and where he's come from, and what he's doing in between ship visits, because again, he could be a classic typhoid Mary, where now you all of a sudden have wiped out 3 ships because this person didn't screen appropriately, didn't wear PPE, whatever. So we're back to the human factors piece of this whole exercise, which is putting out an email, putting up a poster, however you want to communicate with your crew to say, okay, listen, guys, I'm serious. You can't do the following, or you must do whatever. Is one way to do this. But I think people truly do need to be sat down and understand, what does this mean to me? And it goes back to those guys who drove together in the car. I mean, they well-intentioned, but didn't kind of make that final step. How's this going to impact me? So,
John, I've got a question that's not specifically marine side, but it's sort of a generic question.
Yep.
And I'm not a doctor and certainly not an epidemiologist, but is there a certain inevitability to this, that by flattening the curve, invariably, if there is no magic solution of a vaccine, that over some prolonged period of time, we will all be exposed to this? Is that the case?
Yeah, that is basically how it will play out. We've all heard of herd immunity, and so there is a point where enough of us, and I've seen such variable numbers. I still don't know what herd immunity the number is, but from 50% to 70%, whatever the number needs to be. And really what that means is you've got a number of people who have been exposed. They've got some antibodies. They have some degree of immunity. We don't even know how long the immunity is going to last if you are immune, right? And maybe there's variable immunity. Maybe there's like sort of immune and really immune. I don't know. Maybe it only lasts for a few months. Maybe it lasts for a year or two. We just don't know any of that stuff. But let's assume that we stop time. A number of people get infected, which is what you're suggesting, and that's that's the way it has to work. It's going to continue to spread. We're not even at 1% yet, but you know, it's going to continue to spread. We will then develop people who are immune in various places. And really what that's effectively doing is it's making it less easy for the virus to start jumping
like
around.
stopping a forest fire by cutting trees, essentially.
Exactly. It's the same, exactly the same sort of concept. So at some point, it then just is unable to reproduce.
Runs out of fuel. Yeah.
Runs out. Yeah, but then it becomes part of the background noise. Like this virus has basically been added to our file of seasonal or recurrent viruses that are going to be with our human species forever. Until, again, unless there's some kind of treatment or eradication method, but it'll just be part of the regular influenza that comes every year. It'll be this outbreak of Ebola that's just, you know, popped up again in the Congo, or Democratic Republic.
So John, that would imply there will be changes of business behaviors and social behaviors, fundamental ones, for a long time. This is not a tactical solution to a problem. This is going to be something that we may be changing methods of operation for a prolonged period of time.
That's the way I've kind of, no one's suggested otherwise. Again, there's that sort of the fantasy talk, the Boris Johnson, the Trumps and whoever, who are kind of talking about we want to go back to normal again. I mean, the normal that we knew in February, it just, like, I don't know how large gatherings at concerts and you know, and even the packed in restaurants, the bars that were crawling with people, I just don't know how that's possibly going to return again for some time to come. Like I just don't see how it's possible. So yeah, I mean, we have a new thing that's going on, and none of us have ever experienced it. So it's hard to wrap your head around and say, well, what? I have nothing to compare to. But that seems to be, if you look at the viral biology, that's the nature of the beast.
So there's two questions arising that are kind of related. One is, it's obviously a key issue. So can you expound a little bit on prior to boarding self-isolation? How do you see that working? What are the options in terms of how to do that? Maybe just a few more words from you on that.
Yeah, okay, sure, thanks. So yeah, I mean, I'll give you an example of the multiple commercial fishing companies that we've been working with, primarily, I guess a few others too, but so what they've been doing is they've been instructing their crew members that they need to lead an isolated life, which is, again, not terribly inconsistent with their normal, which is good, but make some modifications that are appropriate during that 14-day period. And the same as going out shopping, whether it's the seafarer, him or herself, or a spouse. When you bring stuff back, you basically clean off the outside of the cereal box and the soup can and so on, which again seems bizarre, but what if someone with COVID touched that soup can and then put it back on the shelf again? So you know, trying to be mindful of how can the virus basically get at me in my little bubble world, and then transport yourself from your isolated existence to the port of departure. And when the 30 guys get together, keep yourself physically distanced. And what we've been doing, and this is not something that we have to do, but I mean, the company needs to sort of figure out how they want to do it. We've been doing it as kind of an arm's length service for the companies. A health provider or someone with a thermometer and a little checklist basically goes through the question. So have you been exposed to anybody who's been, you know, potentially COVID proven or possible? Yes, no. Travel outside the province, still in force. Any symptoms of any of these things? Blah, 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 blah. No. And then we do a temperature. And we do a temperature check on these people using a well-calibrated device. And we're using a lower than fever diagnosis. In the textbook temperature of 38.0, we're using 37.5, just based on the years of experience of seeing people, adults with a 37.5 or higher temperature, is often there's something brewing, and that's kind of like that early detector temperature. So it's got to be done well. Even just taking the temperature has got some nuances to it. You can't come in from the cold. You can't have your hat on prior to having your temperature forehead thing done, you know, if it's an infrared. The ear device needs to be properly positioned. So there are some important things. You shouldn't be just doing temperature checks as theater. It's got to be actually a legitimate temperature check. But that's kind of like our final phase. We haven't been doing COVID testing on people. It's expensive. It takes time. And as you already saw, if you properly self-isolate, and you can do a final check on people. I'm touching wood right now vigorously, but we've been lucky so far in the last 3 months of doing multiple crew changes for multiple companies. I mean, hundreds and hundreds of people are now come and gone and multiple times using this method. And again, touching wood, we've been lucky so far. The other good news around this too is that that kind of practice has greatly reduced the common cold and probably will be good for influenza too. Yeah, so we haven't been seeing nearly as much of those sort of things. A little bit of seasonal allergies have popped up as kind of a confuser, but that's really the best method. And then despite that, I'm still saying for the first 14 days on board, you never know. Did someone make a slip that we just didn't pick up on? Let's assume there's still someone on board that's COVID positive. Let's check those temperatures. Let's keep the masks on when we can. Let's do some physical distancing during that first 14 days. If it's going to be a longer trip.
So John, I know this was not meant to be a sales presentation per se, but there's questions coming in. If there were specific marine operations companies that needed some short-term consultancy around those processes and procedures, presumably that's something that PRAXES could provide for them. Is that fair?
We've learned a lot from working with these companies. So this has been an empirical experience as well as reading lots. I mean, yes, so that's something that's interesting to us, and we'd be happy to help. I think we've accumulated a fair amount of empirical experience over the last X number of months trying to figure this stuff out.
I've got a few more questions coming in. I've got one I want to throw, and then I've got a few more coming in on the screen.
Yeah.
What about cleanliness and sanitizing on board a ship? Are there any specific comments you could make there? What sorts of things should the crew and captain be considering in terms of that?
Yeah, great. So yes, I think having more hand sanitizer available to people is good. So trying to put those in a few different spots. One of the companies we deal with actually hired an extra person on their crew whose job it is exclusively to just do cleaning, and they basically start at the top of the ship and they work down to the bottom. And when they're done, they go back to the top and they just basically do that during the trip. Again, at least for the first 14 days, right? You can slack off once somewhat. I think it's been good for us as humans to actually up our game in terms of personal hygiene and to sort of being aware of where our hands are going and not coughing and sneezing in the usual sort of gross way. So, but all the contact surfaces need to be looked at, and how many places do people put their hands? Wow, geez, a lot. Handrails in the hallways, the waterproof doors, all that stuff. I mean, there's places where we end up touching, going into the galley, the ketchup bottle, the salt shakers, all those sort of things are multi-person contact points. Food services, galley. Sort of individuals grabbing onto the spoon and ladling on whatever they want should change to someone actually spooning out the stuff. So one person that's sort of taking care of that, come with your plate. Smaller groups of people eating together as opposed to large groups of people, so different staggering times. There are a number of kind of behaviors that you need to really entertain and think about. Especially around the bathroom cleanings, but in terms of just trying to minimize the number of times that people are piled in together. Certain ships are going to be more amenable to that, other ones not so much. But I think if you kind of look through what's the day in the life of a seafarer on board this ship look like pre-COVID, and what are the things that we can do to try and minimize the touch parts and clean those and be aware of them. There's a lot of really good strategies that people are coming up with.
There's all sorts of studies that show that companies that do extensive first aid training with their staff, the prevalence of incidents and accidents goes down because people are more mindful. Is there a sort of an element of that in this? Should we be doing more preemptive training and awareness raising among crews?
Yeah, no, I think, absolutely. Again, I can't emphasize enough about the prevention piece of this. The goal is to keep virus off the ship, period. And so whatever one can do prior to getting on, walking up the gangway, is what you want to do. We don't want to be like that Atlantic Destiny ship in Seattle, and have to now, do damage control, and or like all the cruise ships. When this thing first broke back in 2019, and early 2020, all those cruise ships cruising around with people that are progressively getting more and more infected as they went around. I mean, that's just that's just it's horrible. Yeah, exactly. So I think you really do need to think about what can we do to keep our crews healthy. And this has been a real benefit of the COVID thing, is people are actually now aware of the health and safety. It used to be, HS&E, and with the H kind of totally forgotten everything about safety. But I think the health piece is actually, people are becoming a bit more aware of that. And, how do I keep my immune system good? And maybe I should be eating better. Maybe I need to make sure that the stress, and maybe there's good sleep available. Transport Canada actually just last year, was one of their focuses was around crew sleep and alertness, and all those things are important to keep crew healthy. But as you mentioned, the more you talk about this stuff, and the more you again do that eye contact, so you say, okay, Joe in the engine room, how does this change of behavior affect you and what you do in your job? Let's walk through a day in the life of the engineer. What sort of things can you do differently to be safer from a COVID point of view, and maybe a side spin is, and maybe even safer just in your job in general.
A question coming in just on the chronology, the evolution of this. So I'm initially exposed by whatever means to, the virus. Just walk through on an average case basis, how long do things take to progress? In the case of the question, they're saying, how long from that first no symptoms to needing medical attention? Yeah. Recognizing it's probably variable individual to individual, but can you just walk us through that a bit?
Oh, that's great, thanks. So there's a couple pieces to that. One is, what was the viral load that one got? And that seems to be a factor. So again, if I'm with somebody who's sort of at the height of their viral shedding, I'm with them for a number of like an hour or so, and they're, whatever, I'm sucking in a whole bunch of virus, and I'm getting it into my lungs, and seeding it deeply in my lungs. I'm going to get a worse, probably faster, potentially even more severe event than somebody who touches a surface where the viruses are almost dead, and I get a couple of them, but it's sort of a lower dose. So, and it's going to depend on sort of how it gets in my body. So you're right off the bat. I mean, there is going to be some variability. But if you sort of take a group of people who are COVID positive, what does this look like? So the virus gets in your system, completely nothing going on in terms of symptoms. It starts to it finds cells that it wants to replicate in. And there are certain cells with receptors that are more likely. So again, the respiratory tree system, the lungs, the bronchi, and so on, are more likely to receive virus more happily than other parts of our body. But it can go anywhere. Then it replicates, and it starts to replicate, and it basically starts damaging cells. As it gets to the replication form, at a point where it can't be contained inside that cell, it basically just bursts and breaks that cell. And so you start getting cellular damage as a result. Again, at this point, you may not have any symptoms. You might get a little sort of something, maybe a bit of a cough, but maybe not a whole lot. The immune system then is now starting to be triggered by this new virus. And so again, we're now 3-4 days into this whole thing, and the very first prototype immunoglobulin or antibody is formed. It's called the IgM. And so it's the first one that starts to try and fight back this thing. And it's pretty good, but it's got like a handgun. It's not sort of, it doesn't have a lot of ammo to work with, but at least it's a start. And simultaneously, the IgG, which is a more specific, more sophisticated, stronger antibody is now being developed. And so IgM around day 5, and that's when people start developing their symptoms. So we often sort of see the peak of symptom development on around day 4, day 5, and that's because the immune system is now starting to kick in. There's a release of inflammatory chemicals that are starting to cause some symptoms as a result of the inflammation in response to this virus. And then the IgG starts kicking in around day 6, 7, 8, somewhere 10, maybe it's kind of variable. And that's where the hammer sort of starts to fall. So again, a person with a more severe infection may, again, be relatively asymptomatic for the first few days, starting to develop symptoms a bit earlier on, and then start getting more severe. But that's probably around day 6, day 7, somewhere kind of later. So again, what I was saying earlier, if you get someone who's got symptoms right this moment, they have been virally shedding prior to that. So wherever they've been touching and going for 2 or 3 or 4 days before that, that's where this thing gets spread. That's the pre-symptomatic phase. Day 4, day 5 is where you'll start seeing some people with symptoms, and then you still have some time between symptom onset and now, you know what, this person's actually getting pretty sick. This is one of the unlucky people. 80% of them, as I mentioned earlier, will go through this like a bad cold, like a bad flu, maybe like not much of anything, and then will recover and uneventful, stay at home and just power through with a couple of Tylenol. About 15–20% will get sicker. They get admitted to hospital. They require oxygen supplementation. So, you know, the little nasal prongs up their nose, maybe a mask if they need more oxygen. They stay on that for 5 days, 6 days, and then they come off it and they go home. But then a small percentage, so we're now down to 3, 4, 5% or less, are going to end up having to be in the ICU and intubated on a ventilator, and about 50% of them die. So, you know, but that's a time progression. So like I said earlier, if someone was to develop symptoms of COVID, they're not going to all of a sudden crump or get super sick. It's going to be a progressive thing where you can organize the ship diversion, have Coast Guard come out and take the person off, get a medevac if that's required, whatever the circumstances. Many ships do carry a bit of oxygen, but you can't carry unlimited numbers of tanks. The more flow you put on, the shorter the tank is going to last. And so it'll buy you a few hours of time, but it's not going to buy you
days and weeks.
Yeah, exactly.
This is fascinating, and our time is run down. But there's one more question, just to confirm sort of thing. Question coming in about a lot of the scientific missions this individual is aware of are switching to single occupancy cabins. Does that make sense? Good thing to do?
Yeah, I think ideally it's missing. The nursing homes have taught us a few things. That's again one of them. I think if that's possible, then that's good. Again, having said that, well, yeah. So if you're doing screening on top of that, like you're doing isolating and screening prior to getting on board, again, the goal is 99% sure that no one on board my crew has the virus. But if there's still a 1% or 2% chance of maybe there is, then not having people crew together, if possible, or sleep together, is obviously that much better. So now we're not breathing each other's aerosols. And if one guy's breathing out virus, you're not now going to take out 2 guys, one of who becomes asymptomatic, and so yeah, absolutely. That's really just physical distancing at night.
Yep. There's a question here that's kind of more in the grand philosophical category, which is, how does this situation differ from the pandemic of 1917-18? We are 2 minutes over time, but if you want to stick handle that one for a minute or two, that'd be an interesting way to end our conversation.
How does it differ? Yeah, so that's a good one. And I probably, it's because I was reading about that a little while ago. I probably have a more detailed answer with facts and things, but I think so the key differences that I'm aware of is, first of all, it is 2020. We do know more. We have more technology. We're aware of the second wave, although again, we're talking about, everyone knows the second wave is coming, and yet we all kind of want to do, all get back together and all be normal again. And so that's kind of encouraging the second wave. But I think we're probably more aware. We're going to be better prepared when another wave comes, because the PPE, obviously we were short of all that stuff. I think people are now more tuned to having the distance, so we may have to, when a second wave comes, which was the bigger killer in the 1918 pandemic, that we'll be able to kind of turn some of that stuff back on again, and people will be reluctant, but they'll get it. So I think we're better positioned than we were then, but there are many similarities for sure.
John, I'm going to end it there. First of all, I want to thank you. You're a busy individual these days, I know, given the circumstances. So we really appreciate you taking an hour of your valuable time to spend with us. We've had, I think, upwards of 60 or 70 people online. Some really wonderful questions coming in. On the screen, I think you'll still see the contact information for PRAXES. And I think it's fair to say that if there are further questions, they can reach out directly to yourself or to Michelle at PRAXES. Is that fair?
Yeah, happy to do that. Yeah, and thank you for again enabling this to happen, and it's been fun to talk to you.
It's been a pleasure, John. So thank you, folks, for joining us. If you're interested in the greater things we're doing here at Cove beyond this presentation, I invite you to go to our webpage, which is www.coveocean.com, and please join us for some of our future presentations. Thanks again to Dr. John Ross for joining us and giving us some wonderful insights into the COVID-19 situation and how we can all respond as professionals in the marine environment. Have a good day. Thank you.
Thanks, everybody.